Hi, I'm Jack Cush, and this is QD Clinic, Lupus QD Clinic. Today's case is about young patients who have SLE. What made me think of this was this case of a 20-year-old African-American female who I saw who was diagnosed about 7 years ago. At that time, she presented with a lot of systemic features, arthritis, abnormal LFTs, but ultimately was found to have a positive ANA, positive SM, positive RNP, inflammatory polyarthritis, evidence of proteinuria and nephritis, although she was never biopsied. It was presumed she had nephritis. She had acute malar rash and other acute erythematous rashes, leukopenia, thrombocytopenia, and Raynaud's. So over the years, she was initially diagnosed at Children's Hospital, and as they get older and bigger, she gets referred to me, the adult rheumatologist, and I've been managing her for a few years, and she's a great patient. Her disease has been complemented intermittently by abnormal LFTs, followed with hepatologists, hypertension, a bout or two of leukocytoclastic vasculitis and nosebleeds. She has been managed over the years with a number of different medicines, hydroxychloroquine, steroids, and then a multitude of other things. Her current medicine, when I saw her, she was on mycophenolate, hydroxychloroquine, lisinopril, and not on steroids. But I bring this case up because I think I want to bring up the challenge of young people. It's a hard diagnosis for them to understand and manage and cope with. There's a lot of resentment and animosity and denial. You know, they'll do some research, and sometimes they'll do no research because they don't want to know anymore, because they don't want to believe that they have it. This manifests with noncompliance with visits and noncompliance with medicine. Coping is a really difficult issue, and my issues are what are the steps you need to take to manage a young person who's starting out with a diagnosis? How do you get them to become a better patient? You know, and basically you have to build a better patient with all your patients. And that's through slow work, concern, and education. So in her, the initial step was steroids. You know, and steroids made her feel good, but you give steroids to a teenager, they're going to be pretty pissed off when they come back in 2-3 months, and they're 8 to 12 pounds heavier, and they've got acne, and they notice all kinds of steroid side effects, including that they're not sleeping, and maybe that's giving them more pain and ache and fatigue. So you got to deal with steroids in them and set expectations and try to, I don't put anybody on steroids without, number one, having an expiration date on when I'm going to stop it. And two, with that, I first scare everyone with all the side effects of steroids so that they're motivated to get off of them. So the next step in her was to let her understand the importance of co-management between me and her, and I need another person. You cannot manage a young person, a teenager or a 20-year-old, by themselves, because that's just a bad formula. You need another very, very close person. Usually it's going to be a parent, but it might be their sister. It might be their best friend. It might be their husband or live-in boyfriend or girlfriend. But it's got to be someone who you turn to at every visit. After you tell the patient, I'll see you back in 3 months, and then you turn to the other person and you point at them and say, I'll see you back in 3 months. I need you to be here as well. I need you to be involved in this care. She needs you, I need you, let's make it a team. And I think co-management by the family is really important. You look for signs that things are not going well. That would include non-compliance with visits, non-compliance with medicines. You do compliance with medicines by putting them on hydroxychloroquine and then checking hydroxychloroquine levels, aiming for 1,000 to 1,500 as your target dose. People have asked, I heard people ask Michelle Petrie recently, do I want to do trough levels or peak levels? What's the deal? And Michelle says it doesn't matter. It behaves like an A1C. As long as you don't get the blood drawn like 20 minutes after they took their dose, you're going to be fine with whatever the value comes back as being representative of them taking the drug alone. The next, so you want to find signs, and you can do it through of noncompliance by checking blood levels. You also want to see, what are they doing? Are they going to school? Are they working? Do they have a career? Is their life stable, both at work, avocationally, relationships, family? Who are they living with? What's going on there? When you get the picture that they're floundering and they have no relationships and they're not coming with someone else, I worry about that. You ask about their habits. Do they smoke? Do they drink? Are they sexually active? Because they'll tend to tell you the truth on these things. And are they sexually active? And again, you have to assume everyone in this age group is sexually active and push hard to get everyone either on an IUD or a progestin implant. That way you don't have to worry about compliance and worry about the potentially additive harmful effects of an estrogen-dominant oral contraceptive. So again, showing concern at each visit is going to be really important to get that patient to self-reliance. And then if the patient is a pediatric patient, the transition from pediatrics to adult rheumatology is going to be a rough one. It's got to be a very close, if not person-to-person handoff between the doctor they trust, the pediatric rheumatologist, to the doctor who they're going to be asked to trust, which could be the adult. Again, I have a greater degree of concern and involvement in young people with lupus. I think you should too. Tune in for more QD Clinics.